Good afternoon, everyone, and welcome to this week's Black Health Trust program. It's a beautiful day in many neighborhoods across the U.S., and I'm coming to you from Los Angeles. I'm your host for today. Today, our panel will be moderated by the distinguished Dr. Randall Maxey, Chief Medical Officer of Advanced Community Medical Care Corporation and co-founder of the Black Health Trust. He will introduce our wonderful co-moderator and our guests today. I'm going to read the mission statement for the Black Health Trust now. The mission of the Black Health Trust is to provide credible insights from our community health experts to best serve our communities of color with a coalition of leading and long-standing Black medical professionals across a diverse spectrum of disciplines, and to offer unvarnished opinions and insights into our physical and mental health during these especially challenging times. I'm going to share a few housekeeping items and announcements for the program now. Please be advised that this video conference is live and is being recorded on different public platforms such as Facebook Live and YouTube. That participation on this call is completely voluntary. If you choose to participate on the program and prefer not to have your image and likeness displayed, there are audio and visual settings on your device that you can use to block your picture and mute your voice. Everyone's audio is being muted by our technician initially. We ask that you remain muted if you notice that you're for some reason unmuted until the host or facilitator asks you to contribute in order to minimize the distraction of background noise. So please check periodically and make sure that your device is on mute until called upon to speak, and then once again, place your device back on mute when you're done speaking. As for the chat room, if you have questions, you may enter them in the chat room. Please limit your questions to 2 per topic being addressed, and please do not use the forum to advertise or promote your products. Understand there may not be sufficient time to get to all the questions during the call, but we'll do our best. Most of you who've been on the call before know how this rolls, so appreciate your patience. Please be advised that the information contained on this program is not deemed to be medical or legal advice, and you should always consult your own medical or legal professional for advice pertaining to your particular situation and needs. So here comes the promotion for BHT. We need you to continue bringing our community outstanding programming, critical and timely information. Please visit www.blackhealthtrust.org. We need your support. Visit the website to learn more about our programming, how to support, volunteer, and or donate so that we can get this information out to even more people than are on this call. So again, visit our website, blackhealthtrust.org, and donate whenever and however often you can. So later on, we'll have a member of the executive board talk more about BHT later in the program and how you can get involved. And I want to thank, before we move forward, I want to thank the Black Health Trust Steering Committee, as always, for the hard work that you do to make this program possible, our virtual assistants, our production and Zoom technician, and all the people behind the scenes for their time and efforts that make this program what it is. And we thank you sincerely. We also want to give a big welcome to all of our distinguished physicians and special guests today. We thank you for sharing your time, your information, and your educated insights with us. Your participation and support is invaluable to our communities of color. It's a critical time. This is critical to our present, our future, and we appreciate you so much for your knowledge. So welcome again, everyone. Grab your coffee, tea, lean in. Dr. Maxey, please do us the honor and begin moderating the program.
Thank you very much. So wonderful bringing us in every week. We appreciate you. Welcome, distinguished speakers, and to our guests. The Black Health Trust was founded to provide credible information in a time of hazard. There's all sorts of information on the internet and on the TV, and many people don't know who to believe and who to trust. We have made the vow to become that trusted repository of information regarding health and health disparities, especially for communities of color. We have an advisory board of distinguished physicians from across the nation and across the world. And in addition to major healthcare professionals, not only physicians, and we know that your mental health, as well as your physical health and spiritual health, are all one. And it depends upon everything in the nation, from law enforcement to hospitals, physicians, as well as the information that you see on the media. So we have incorporated all of that. We have a repository of all of our previous programs, and today will be the same. This will be on our website. We know we've had a lot of political upheaval. We've had the winds of change. Many people feel relieved. Many people are happy. Many people are partying. But we still know that there's big problems going on with health. We are going to have a special guest. As soon as you see him, Michelle, you will let me know, Mr. Hewitt.
Sure will.
In the meantime, Simon, if you put on the first slides, I'd appreciate it. Go ahead. We know that the pandemic is very real. Go to the next slide. Go to the next slide. And we know that the total cases have been increasing on a daily basis. The total cases in the United States today are 9,808,411. The numbers we gave last week showed that there were only 9,105,230. So there have been 93,811 new cases just over the past week. There are a total now of 728,598 cases over the last 7 days. The total deaths that we have experienced in the United States is 236,547. That's several football stadiums worth of deaths and cases. Just over the past 24 hours, there have been 1,072 new deaths that have occurred. I'm concerned, and I'm very glad that the new administration has announced that as of Monday, tomorrow, they're creating a new task force to start to deal with getting these numbers down. I'm very concerned that we stay alert, we stay involved, that you continue to protect yourself. We know that wearing masks does decrease the amount of droplet spray. We saw a very dramatic lecture last week from Dr. Salafu, who showed that when you wear a mask, it dramatically cuts down the droplet spray and the aerosolization, and that is very important. So wearing a mask will protect those around you. If you're a health professional, we know that you have access, we hope, to N95 masks, which will protect you. So wearing those coverings are very important. Wearing gloves is important. Gargling in the morning is very important with hydrogen peroxide or Listerine, because we know that this virus can enter into the ACE2 receptor, which is mostly located in the back of your oral pharynx. We know that we should be eating more micronutrients. We should be eating a high amount of antioxidants. We recommend for many people doses of vitamin D3, vitamin C, zinc, and other things. You must have your immune system. In order for your immune system to be good, you need sleep and you need exercise. So we're going to move with our program. My very brilliant co-host, co-moderator today is Dr. Barbara Nabert-Stephens, who I met just a few years ago when she was 15. She's now 18 years old. And somehow in those 2 years, she got to be a major physician on the board of trustees of the National Medical Association. And now she is in the leadership of a major health plan in Tennessee. Dr. Nabert, would you introduce yourself and have a word about our current healthcare situation?
Good afternoon, everyone, and welcome to you from Nashville, Tennessee, where we too are having a beautiful day, bright, sunny, unusually warm, more like a spring day. And I think it is an invigorating day. It's a time for everyone to exhale, regroup, and move forward. I want to emphasize my 3 W's again that Dr. Maxey just went over. It's almost a litany that we can just repeat periodically during the day. WWW. Wear that mask. Wash those hands. Be aware of safe distancing. I'm telling you, it's a time of accountability. It is a time to hold others accountable, but it's also time to hold ourselves accountable and for us to do as much as we can to protect ourselves. Dr. Maxey, are we ready to go forward in the program?
Yes, we are.
It is my pleasure today to reintroduce and to present again a speaker that was with us several weeks ago, a person who has the opportunity to be right in the middle of the fight in terms of identifying and developing therapeutics to help us in this war against COVID. I'm speaking of none other than Ms. Deborah Wafer, who is a nurse practitioner and is currently working with Gilead Science Incorporated. Now that name may be ringing a bell to you, with you, because that is one of the companies that is in the race to try to bring to market an effective therapeutic against COVID. Her role with them at this point is as an HIV prevention medical scientist, but all of us have found ourselves shifting gears in the midst of the pandemic. However, her work in the HIV world has included provider and community education around PEP and PrEP and other prevention modalities that are in place against HIV. Prior to working with pharma, she was a clinician at UCLA Medical Center in the Clinical AIDS Education and Research Center, where she provided primary care and coordinated clinical trials for people living with HIV. In reviewing her CV, I found that in our previous lives, our paths were running in parallel, as she was working in research protocols that led to the introduction of a protocol for pregnant women that decreased HIV transmission. We called it vertical transmission between mothers and infants. And for those of you who weren't born or are too young to remember that time, it was a very scary time because similar to now, we didn't have anything to prevent the disease or treat the disease. We were at the very early time of the HIV period, and we were dealing with vertical transmission between pregnant women and their unborn babies. And I too was involved in some of the early research at Meharry on transmission prevention. So at this time, I'd like to present Ms. Wafer, who is going to give us an update on how things are progressing in the efforts to bring effective therapeutics to market. Ms. Wafer?
Thank you, Dr. Stevens. Can you guys see my screen? Okay.
Yes.
All right, good. So then I'll go to slide mode then. Thank you. And I'm going to come back to where you just left off about vertical transmission, because it ties into what I want to talk about today. As Dr. Maxey talked about the epidemic that's going on right now, I want us to not forget about, we have 2 pandemics going on. We have HIV and we have COVID. And in both of those epidemics, African Americans, Black people, and brown people are not doing well. We are the folks who are most impacted when you look at both of these diseases. And you can take a look at this map and it shows you the blue map is COVID cases per 100,000 cases. And the other orange red map is the HIV cases per 100,000. And what you will notice is where the colors are the darkest, that's where most of the epidemic is occurring. And take a look at the South, because I think that's one of the areas that does not get enough focus when it comes to resources, when it comes to having enough providers. There are a lot of healthcare deserts in those areas. And it's also the same place where they did not adopt the Affordable Care Act. So when you take a look at that, you can see how they overlap and how they impact our community. The thing that's not on here is that just like HIV happened here in the US, and then it blew up when it came to the continent of Africa. And we don't see a lot of cases of COVID now, but I think we still need to pay attention to that because I think that's what's going to be coming. So that's, we know that some of these issues are related to long-standing problems in terms of health inequity, but it's important for us to just keep that in mind, that HIV is still at epidemic proportions in the United States. And right now, we haven't seen a real correlation between people who have HIV acquiring the COVID-19 doing any worse, but we don't have a lot of data on that right now. What we have seen is that some of the HIV medications are helping people do better if they come in contact with the coronavirus. But that's another topic, so I won't go down that rabbit hole today. When we look at these numbers right here, this takes a look at the cases by race. And I don't think I'm telling you guys anything that you don't know, but you know that Black people and Indigenous Americans are experiencing the highest rates of death when it comes to COVID. And I didn't talk about that on the last slide, but it's also the same thing that's happening with HIV. People who are living on the reservations are having more HIV and dying at much higher rates, and not a whole lot of people are paying attention to it right now. Then here, I just wanted to, I think I showed you guys this the last time I was on talking about COVID and the racial disparities when we look at African Americans. I know I'm speaking to the choir now, but I just did want to give you some numbers. This is through April 20, and those numbers are higher now. African Americans, we account for 11% of the population, but we account for more than 28% of the deaths from COVID. And if you look at the cities where this is impacted, the first dot shows you the percentage of the population, and then the green dot shows you the percentages of deaths. So places like Missouri, where Black people are 11% of the population, but almost half of all the deaths. And then you look at Mississippi, and you see that they're 38% of the population and over 63% of the deaths. So just something to keep in mind as we do our work, and those of us who are in positions to speak up and address this, that we have to always keep our minds on these numbers. Okay. Now let's talk a little bit about HIV. The rate of the number of HIV cases has gone down slightly. It's around 38,000 new cases a day. This is data from the CDC, and you guys know the CDC is always late with their data, but this goes through 2015. The first chart shows you the number of HIV cases overall in men who have sex with men. And then we see the bottom line is men who have sex with men and women, and then heterosexual women. And those numbers are going down. And I'll talk about that in a moment. But if you look at the second chart, it takes a look at the number of cases total cases, African Americans, Latinos, and whites. And again, African Americans have the highest number. I saw we have Dr. Puckman on the line, and he probably has more data, and maybe we can talk about that later. I know he tracks this data very closely, and maybe you could say a few things about this when I'm done. Then we have, so what's the reason that the number of cases in women have gone down? Some people believe that the reason and the number of women has gone down is because we're much more open about sexuality than we were at the beginning of this epidemic. And maybe that is the reason fewer women are acquiring HIV, because they're not having sex with men who are having sex with men and women, because people can be more out about their sexual identity. I haven't seen any papers that prove that, but that's something that folks are thinking about. And I think that's a good thing. Here we have a slide about PrEP. For those of you, let me just do a quick plug on PrEP. PrEP stands for pre-exposure prophylaxis. So medicine that you can take that will keep you from acquiring HIV. There's also PEP, which is post-exposure prophylaxis. So that if you had a needle stick or you had sex with somebody, condom came off, you don't know if they're HIV positive or not, you could go and get some medication and take it for about 3 or 4 weeks, and it would block the transmission of the virus. But if we look at PrEP, PrEP is something that really can get us to the end of this epidemic. But this map is just like the maps that I showed you in the beginning. The darker the areas, the fewer people who are on PrEP. And so it's estimated that around 400,000 Black men and women are indicated for PrEP, but that many people are not on PrEP. So I'm talking about this today because I think it's important for us to know that HIV can be prevented. It can be prevented if people are on PrEP. And if you're seeing patients or you know of friends and people who are having reoccurrent sexually transmitted infections, you might want to talk to them about PrEP, because if they're having sexually transmitted infections, that means that they're probably having sex without condoms, and they are having sex with people who have STIs. And if you have an STI, the acquisition of HIV is a lot easier. So I'm showing this for everyone to know that HIV can be prevented, and it can be only prevented if you take medication for it. It is medication you have to take daily. The company I work with is Gilead Sciences. We have 2 medications for PrEP, but we're not the only ones. There's new medications coming up all the time. Another company is working on injectables that people would take maybe every 3 months, maybe every 6 months. Some of them might be every month, but they're working through that right now. So this is important as we look at trying to control this epidemic in our community, and it's a pandemic in the world. Now I want to go to just a case here to look at what could happen if pharmacists were prescribing PrEP. Pharmacists are medical providers, and California just passed a bill called SB 159 for if a pharmacist gets their training in PrEP, they can prescribe PrEP at the pharmacy as long as they can hook the patient up with continuity of care. So they can dispense 60 days of PrEP, and then the person would have to make sure that they follow up with a healthcare provider, because there are labs that need to be monitored. And in New York, the state of New York, this is already something that's been happening for a while. This bill was approved in California in July of this year, yet there's still not a lot of pharmacists who are doing it. So if you know any pharmacists, ask them about this and see why they may not or they could be doing it. But if you take a look at this, this was a pharmacist-run PrEP clinic. And it was done in New Mexico, where there are a lot of health deserts. And starting with the first bar, there were 182 people who were scheduled for a PrEP appointment. And then the number went down to 134 of the number of people who actually attended the clinic for the PrEP appointment. And then there were 126 or 95% of the original number who were actually prescribed PrEP. And then there were 95 of those people, or 75% of those people, who showed up for a follow-up visit, and meaning that they took their medication and they were either seen 1 month or 3 months after their visit. And none of the people, there were no new cases of HIV in this population. And I just like to say also, if a person comes in and says, I want to go on PrEP, it's important to not turn them away, because people know what they're doing, and they know if they come in and ask you for PrEP, please try to find out what it is or how to do it. Don't tell them, I don't do that, or I don't know what you're talking about. I had a clinician friend who said she had someone come in and said they wanted PrEP. So she had to go to her office and Google it and find out what they were talking about. But she did it, got the person on PrEP, and probably, avoided new cases of HIV. So I just wanted to talk about this because I think this is something that's going to be happening more and more. Colorado is looking at it, and the state of Nevada is also looking at it. And as you know, there are a lot of mini clinics at CVS and places like that where people go for their episodic care. And Walgreens and CVS are looking at how to institute this in their clinics. And I think that's a good thing for people out there who may not be able to always fit into clinic hours Monday through Friday. This last slide is an example of what ending the HIV epidemic is about. This current administration has an initiative called Ending the Epidemic, and Ending the Epidemic is about having funds to certain zip codes where we know that the rate of HIV is high, and funding those zip codes so that we could decrease the number of HIV cases. This is from San Francisco, and we know that this might not be something we can do everywhere, but I think the pieces of this are important. In San Francisco, they wanted to decrease the number of new HIV infections. And so they were working, they started going backwards after a few things came into place. The first thing was PrEP. The other thing is something we call U equals U, or untransmittable means undetectable means untransmittable. So if you look at this, this tells the story of starting in 2006, the city of San Francisco, citywide, started doing routine testing on everybody. Anybody having sex, get an HIV test and know what your status is. At that time, you can see that they had 530 people living with HIV, which is the blue line, the red line. The blue line is the number of new HIV, and I'm sorry, let me go back. The top number is the number of cases. The blue line is the number of HIV diagnoses, and the yellow line is the number of deaths. And this goes from 2006 to 2016. So we're talking over a 10-year period. So they started with HIV routine testing, and you can see the numbers stayed the same until they started doing treatment as prevention, or U equals U. And you can see there, the number of deaths went down from 327 to 254. But also the number of new infections went down. Where it had been hovering at 500, the number of new infections went down. Because if they take their medication, it's working, their virus is suppressed, there's no virus floating to go out and cause a new infection. So that's what treatment as prevention is, or U equals U. Then you can let's move down to 2012 when PrEP was introduced. And PrEP the medication was Truvada. It was approved for the prevention of HIV. And we can see what happened in 2012 in terms of the number of new cases and the number of deaths and the number of people living with HIV. The number of people living with the HIV went up about 1,000. And then in 2013, they said, anybody who comes in who is HIV positive, start them on the medication that day. Don't send them home and tell them, wait, come back, think about it. Start them on the medication that day. Because if you can start them on medication that day, people are going to have a faster drop in their viral loads. The other thing, if somebody comes in and asks about PrEP, start them on it that day. Don't make them go 2-3 weeks trying to figure out what to do. So then by 2014, they came up with a plan to get to zero in San Francisco. And you can see by 2016, they had a 51% reduction in new HIV cases. The number of people living went up and the number of deaths went down. Now, I know this is San Francisco, California, healthcare, people have more of it. But I think this is a good demonstration to what we can get to. And it's a great model if we could just get all of these things in place in certain cities. And I think this election really kind of pointed out a lot of things to us, to me anyway. When I look at that first slide that I show you, where there are a lot of new HIV cases and people dying of COVID, they're also the same places that many of the red states. And so I think we're going to need some more advocacy for Black people in those cities around the Affordable Care Act. And then let me just go back to vertical transmission, because Dr. Stevens talked about that. With vertical transmission, what that was treatment as prevention. When you treated the mother, you got the virus down, there was no virus to pass on to the babies. So we're not seeing babies born with HIV anymore, because now we know if the woman is HIV positive, start rapid treatment, get her viral load down during her pregnancy and at the time of delivery, and you're not going to see any babies who are born HIV positive. And that's, I'm sure, Dr. Stevens, you're proud of that, because I know I'm proud of that, to have been a part of it. And with that, I'm going to stop because I wasn't even timing myself. That, and I'm going to let go of the screen, right?
Well, thank you so much. That was, that was kind of a walk down memory lane, a bad memory lane. But it shows that if we put our minds and our heads to it, we can make a difference and we can make progress.
Right.
I wanted to push a little bit though on PrEP. Again, I'm in the Nashville TV market, and there is a PrEP clinic here in Nashville that advertises all the time on TV. But what I haven't been able to figure out, and I guess I should also say, Nashville, Tennessee is one of those red states, although I know we're not supposed to be red states or blue states anymore. But it is a red state that rejected Care Act extension, and that has submitted a waiver request to go to block grant funding of Medicaid, which is something that we won't talk about now, but something that as a community we need to be aware of, because it's happening all over the country and what the impact of that might be. But my concern is, if you're aware there is, and almost everywhere this is the case, rising numbers of unemployed people because of COVID, and therefore loss of their employer-sponsored insurance. They live in states that have limited access to Affordable Care Act coverage. Bottom line, they don't have insurance. What are their options? Because PrEP Clinic never talks about how you pay for PrEP.
Right. Yeah, that can be a challenge. And paying for PrEP is one thing, but paying for the lab visits and paying for the doctor visits sometimes is more of a problem. Gilead has a patient assistance program, and if people don't have insurance or they don't have the resources to pay for it, the patient assistance program will help people get PrEP. But what I find sometimes is a problem is who's going to pay for the doctor's visit and who's going to pay for the lab work that has to be done. That sometimes can be a challenge in places where there's not expanded Medicaid. In California, we have a PrEP assistance program that pays for your lab work and your insurance if you and your and your doctor's visit if you don't have it. But if you can get a visit, you get the lab work, the company has a patient assistance program. Dr. Puckman, did you have anything to say?
He's
You're
gonna.
on mute. Somebody needs to unmute you, I think.
He's gonna talk in a few minutes. Can you hear me?
Okay. Yes.
Let me raise a question, and I do want to introduce somebody special too. I believe that in the current United States of America, where people do not, many people, there's 74 million people that said we want health care for everybody. There's another 70 million people who don't believe health care is a right for anybody. What this tells me is that if we don't take care of ourselves, the next time a pandemic, an endemic, other things come along, we're increasingly putting ourselves at risk. And I don't mean to be funny, but there ought to be a tax on people who eat pork chops. We have to be concerned about putting ourselves in the way of things that we know have risk. And we have to start taking authority over our own protection. We might not get away so lightly the next time a worse pandemic comes along. I'm not making a social statement, but to say we have to protect self and our families. And we want to ask you a lot of questions. Are there any questions in the chat box, Michelle?
Yes, there's just a few. So the first is Gilead studying the possible use of antiretroviral drugs as therapeutics in the treatment of COVID-19?
Oh, yeah, of course we are. Yeah, all day long. Yes, we are. I mean, you know, we are the #1 HIV producer of HIV medications, and that's really because our company started in virology. That's kind of what jumped us to get to remdesivir for COVID, because that's what we study, our viruses.
Okay, and this is a general question regarding Medicare, if someone knows the answer to this. Does Medicare cover all labs and doctor visits everywhere?
Medicare, you know, in California, we have Medi-Cal, so that's a little bit different. And I don't know, I think it depends on the state that you're in. I don't know the answer to that. Dr. Buckman, do you know?
It actually depends on the kind of Medicare plan that you have, starting with whether or not you have both Medicare A and Medicare B. And then the question is whether you're on straight Medicare or fee-for-service Medicare or Medicare Advantage.
I think we're having trouble
Will be
here.
covered. Can you hear me now?
Yes, we can.
Okay. It depends on what kind of Medicare you have, and depending on the kind of Medicare you have, it will determine what your deductible is, so you're out of pocket. So you may have 100% coverage if you're in a Medicare Advantage plan, or you may have a 20% deductible that you're responsible for.
No, it's just the rice. I started that.
Okay,
Let me do this. I want to have a good question and answer session with Ms. Wafer and our other guests going on, but I'd like to introduce our special guest early. He is an award, a Grammy Award winning songwriter, singer. He was born in 1955. He has a number of well-known songs. He was previously with a group called Shalimar. We're very happy to have with us again Howard Hewitt, who's been with us. Hewitt, unmute yourself. We are so happy that you were able to join us.
Can you hear me?
Yeah.
It's good. It's good. And it's good to really listen to all this information about certain things that are going on. I'm proud to say that I have Medicare A and B. just a month ago. So like I'm good. I was so happy to get on Medicare because they're killing me on that regular insurance thing. But it's interesting to sit and listen, to everything as far as this is concerned, because, sometimes, as a layman, and I think I can speak for a lot of people when they, that don't really understand the medical terms of things and the medical, when the way that things go in the medical community and stuff. But, because it kind of, when they first started talking about, that COVID. Can you hear me?
We
Yes,
do. There's a little bit of interference.
Okay, can you hear me now?
We can hear you, Howard. I don't think it's coming from you.
Oh, okay.
Yeah, I just recorded it. I'm supposed to record it when the sing.
There we go. Apologize for that.
But myself and I think some people also like I said that are laymen. We don't know the particular medical terms, medical procedures or stuff like that. Because when they first started talking about COVID-19 being more susceptible to us as Black people being more susceptible to COVID-19, I started thinking, I said, well, what does that mean? That we're different from everybody else, or we're different? But then, listening and getting information that a lot of it has to do with medical availability, where a lot of Black and brown people are, and they're them being, able to get the medication and the type of, procedures and the doctor availability, the medical availability, that has a lot to do with it also in some ways, as far as physiologically is concerned, as far as Black people and brown people are concerned, as far as it has a lot to do with our diet, and which contributes to those underlying, conditions. So, but it's not because we're different from white people. White people are different from us. We're all, we're our human situation, and then that's I think that's what was, important for me to when those reports first started coming out about, it being Black people, brown people being more susceptible to it. Because, one of the questions I asked my people that were listening to me, and I specifically said, to my white listeners, I said, I told them I didn't want them to come and confess or whatever. I said, but how did it feel? How did you feel when you started hearing that Black and brown people were more susceptible to COVID-19? Was that a time when you started saying, oh, well, we should open up? You know what I'm saying? Because we're not susceptible to this. That's why I wasn't really crazy about the fact that, that the media started making those differences, that started announcing those differences, because then, you have those rallies that came up, like I think it was in South Dakota or something like that, where 500,000, bikers converged on this town in South Dakota, and 90 to 99% white, whatever. There were probably a couple of Black, but just a couple of Black motorcycle members of that whole thing. But that's when all that stuff started happening. So I'm glad that we, at least we have I have an idea that that's not what the case is, but we just, as a people, we just have to be a little bit more aware of what what the options are. I don't know a lot about the HIV situation. But I mean, like the COVID-19 situation is very, very interesting to me. And it's just, I'm glad you guys invite me, you know, Dr. Maxey, you know, your second time you invited me onto this situation. So, and I'm just listening. I'm just really listening. I'm getting a lot of information. I appreciate that.
We're glad you're with us. You blessed us the last time. Are you going to bless us again?
No. Man, it's early in the morning. You guys give me early in the morning. I'm just waking up. I was like, yesterday was an amazing day, I think, for our democracy and for, you know, as far as our voices in this government being heard. And so like I you know, quietly celebrated, you know, last night. So I'm just listening today. Huh?
What was it you sang for us the last time that had all the ladies swooning?
Amen.
Amen. Oh, well, the song's called "Say Amen." "Say Amen" was a song that I was blessed to be a part of, to write, you know, years and years ago. You know, myself and my writing partner, this guy named Monty Stewart, and actually, Monty and I went on to write, you know, a lot of songs throughout my career. But "Say Amen" actually was the first song we ever wrote together. We had ever written together, and it was sometimes and I'll say it, you know, and when I'm doing my shows, that sometimes I hesitate saying that I wrote "Say Amen" because it was such a gift, you know, from God. I mean, the way that He brought the lyrics to me, the way that, you know, everything that was happening in my life at that time, you know, contributed to the attitude that I had when I went in and did the final vocal on it. So, you know, it's a very special song.
With God a few minutes ago, and he told me to tell you, you need to bless us.
What's that now?
I just got off the phone, and he told me to tell you, you need to bless.
Who said that?
God.
Oh, God. Well, Dr. Maxey, me and God have a personal relationship too. He said, dude, tired, I'm wiped out right now. It's like, you know, sometimes, you know, because a lot of times, you know, I explain about, you know, when I do like question answer type of things, especially with kids and stuff that are trying to get into the business and stuff, you know, you have to really explain, because some people talk about, you know, they think that vocals and instruments are two different things, but actually, you know, they're all the same thing, actually. In the way that, you know, I always look at and you guys can say, you know, on the medical situation, I always look at my body. My body is like, you know, is the instrument. You know, I don't pick up a guitar or sit behind a set of drums or keyboard or whatever, but my you know, my instrument is my body. The way I keep it together, keep my body together has a lot to do with the strength and the quality and the clarity of my instrument. And you know, and sometimes when you're waking up, when I'm recording, you know, getting ready to record or whatever, they say, well, what time you want to come into the studio? I say, man, my throat doesn't even wake up until about 1, 2 o'clock in the afternoon. So anything before that, I may go in there and do it, but we may have to replace it, you know, later on. And so, you know.
Anytime you want to come back and bless us, or you have a cup of tea or coffee, you want to come back and bless us, you're welcome.
Yeah, so you have an hour to warm up, Howard.
I got that.
By the time this call is over, you should be nice and hot.
That's funny. That's funny.
But thank you for coming on.
Thank you.
Words. I want to move to the next. And first of all, I want to thank Ms. Wafer, and we're going to have a lot of questions for you, Ms. Wafer, in a moment. She's been a good friend of mine for years and years, a good friend of the National Medical Association. And we thank her for bringing her information to us all the time. So don't think we're finished with you yet, Ms. Wafer. We got a lot more. But before we go to our next speaker, I'm going to ask the chairman of our advisory committee, Mr. Carl Brooks, who is formerly the president of the Executive Leadership Council, which represents the top Black executives of Fortune 500 companies across the world. Mr. Brooks, would you come to us?
Hello, Randall. How you doing? How you guys doing? For the last 5 or 6 weeks, I've been speaking to this audience about the importance of voting. And we talked about voting as though your life depends on it. And I couldn't be more proud of the response from our community, record-breaking numbers from the African-American community, the white communities, the Hispanic communities, over 140 people, 140,000, 140 million people voting at the most recent elections. All night long, I stayed up. I know what Howard Hewitt is talking about. I stayed up all night long watching demonstrations and people celebrating throughout the country because they voted, and they voted in record numbers. I couldn't be more proud of that. The communities of Detroit and Philadelphia, my home city, were out all nights, all times of night, celebrating and recognizing the importance of voting. Our life does depend on the fact that we voted, and we've done a wonderful job. The initial indication is that Joe Biden and Kamala Harris will be president and vice president. I couldn't be more happy. We're moving in a direction where we need that kind of clarity. So thank you for responding in a tremendous way, for voting as though your lives depended on it. The second issue that I've raised over the last several weeks is the issue of supporting the Black Health Trust. The vision of my brother, Randall Maxey, to have such a vision to be able to provide proper, intelligent information to African-American communities and others is absolutely essential. Since June, we've had program after program, every Sunday except Father's Day, we've had programs to bring this information to light. We've done it on the shoestring. We've all dedicated and dedicated monies to it, but we need your help. Michelle couldn't have said it more directly. We need your help in order to take it to the next levels. The first stage of doing things is doing for self. We have to help ourselves. We've already set in motion discussions with multiple corporations and others, and we're working with Dr. Ramsey, Dr. Randall Maxey, and Dr. Barber to work on that. We're going to move that forward, and we're making great progress. But we need your help. We need you to give as though your life depends on it. We got to continue to do this. We can't lighten up. We have to move forward, and we need your help. No donation is too small. We need you to help us and make this happen. Thanks again for your participation on the vote, and we need your help on the donations.
Well, thank you very much, Mr. Brooks. As we go to our next presentation, it is clear we've been able to grow our audience from just the Zoom audience that you see to getting to between 7,000 and 10,000 people per broadcast. And we want to expand that. People need credible information. The wonderful health professionals that have volunteered their time each week to give us information, the result of their study is greatly appreciated. But we encourage you to help us reach all 30+ million people of color in this country. And that is very important. My job now is to introduce an old friend of mine that I met when I was still a Cub Scout. I was president of the National Medical Association, or chairman of the board of that group, when I met Dr. Puckrin. Dr. Puckrin has a PhD in history, but he has developed into a major guru of big data. And he created an organization of which he is the CEO called the National Quality Forum in Washington, D.C. This National Quality Health Forum provides major information and research about the status of minority health, not only African American health, but Latino health, etc. He's teamed up with not only the National Medical Association, the American Medical Association, the Hispanic Medical Association, and he has the greatest collection of data I've ever seen, right down to the zip code, to the congressional district. He can influence. I've gone to his meeting where I was fortunate enough to be given a lifetime award a few years ago. And he's got the Speaker of the House of the Republicans, the Speaker of the House of the Democrats, all the people you see in the news at his meeting, both Democrats and Republicans and others. So it's with great pleasure that I introduce and ask to come to the floor to give us information on the status of healthcare in the United States, Dr. Gary Puckrin.
Randall, I want to thank you so much. I want everybody to know I have learned so much from Dr. Maxey over the years. As he told you, my doctorate is actually in history, and Randall and many of the physicians who are part of the National Medical Association, the Association of Black Cardiologists, have been incredibly patient and helping me learn more and more. Because I'm a historian, what I've come to appreciate is data and how to build a data archive. And when I got started back in 1998, there was a real need for a data archive to understand minority health generally and African-American health more specifically. So what I want to talk to you about is really the work that we've been doing over the last 20 years, but now we talk about it in terms of using big data to promote minority health. For those who don't know us, I'm going to introduce you a little bit to the National Minority Quality Forum, and then I'm going to look at 3 programs that we've been working on flu, the COVID vaccine, and then a prospective study that we are working on the virus. So first, the National Minority Quality Forum, we were founded in 1998, and really we see our mission as reducing patient risk. At the end of the day, if you boil it right down, what healthcare is about, it's about reducing risk. And that's what we're focused on at the National Minority Quality Forum. And like I said, we've been building health data. We have a database now north of 5 billion patient records. We collect data on 130 million lives a year. We can take that data and look at disease prevalence and cost by population down at the zip code level, and then we can aggregate it up to higher geographies. To give you some feel for our data, we don't know the individual patient's name. We have a unique identifier, so it's HIPAA compliant, but then we can aggregate patients to the physician who are providing care using the physician's NPI number. We know the pharmacy, we know the hospital, we know what they're being diagnosed for, we know how they're being treated or what medications. Because we present our data geographically, we can look at social determinants of health, household income, education, environmental quality. So we have done work for EPA in which we look at environmental data and healthcare data to talk about the impact of environment on health. We have formulary data, we know out-of-pocket cost, we know the cost of medications, and obviously we know the demographic profile of patients. So big data is really a challenge. It's a lot of it. It changes all the time. And it requires a unique set of skills to manage it well. And so what we focus on is data visualization. What we try to do instead of presenting Excel spreadsheets or SAS tables to people, what we try to do is present the data in a visualized way. And that's what I'm going to talk to you about today. So we've built a proprietary geographical information system. Gary, that's my daughter's name, by the way, and which allows us, it sits on top of all of our data, which allows us to map down at the community level. Because at the end of the day, healthcare is delivered locally. And what you really want to know is how is healthcare being delivered locally, what are the outcomes and what's happening to patients in community. And so that's the way we sort of try to drive it. Just to give you a feel, so we're using aggregated data. We allow a user to come in and be able to query the data really by using a set of filters. It actually allows them to get to understand how healthcare is being delivered, the health status of populations across 72,000 conditions. So rare diseases that impact large populations like diabetes. We also aggregate the data up by congressional and state legislative districts, and we do help members of Congress and state legislators understand the impact of disease in their community. Here's a little map to give you a feel for what we do. We call them indexes because we're just not mapping the prevalence or incidence of a disease, but we're also looking at cost and health outcomes and allow you to filter by race, and gender, and age, and et cetera. So here's a map, 5-digit map of multiple sclerosis. We do a lot of work with MS, and that gives you a feel for where the multiple sclerosis population is in the Medicare fee-for-service program. We actually have Medicaid data, Medicare Advantage data, commercial data, et cetera. And here's MS filtered by African Americans. And the reason why you see all of these maps showing the clustering of disease in the American South, there are 38,000 zip codes around the country where people live. 70% of African Americans live in 2,500 zip codes, and many of those zip codes are in the southeastern part of the United States, the former slave states. That's basically what's going on. And then there's some migrated pattern up here in Detroit, Illinois, and if you drill down, you're able to see. We just don't aggregate the data by geography. We also aggregate by provider. So we can take every patient and aggregate them to the physician who's providing care. And you can go into our GIS system and map by provider so that you can find out all of the providers who are treating African Americans with heart failure or diabetes or sickle cell or whatever it is you want to look at. This is our ATTR index. This is amyloid cardiomyopathy. It's a relatively rare disease, but it has a large impact on African Americans. They're difficult to diagnose. So we are mapping not just the disease itself, but signal symptoms to be able to hopefully tease out where those populations are. And these marks here are really physician practices that are treating African Americans with ATTR. And then you can take that data and pull it out in an Excel spreadsheet, and so we actually know the name and the address of the provider and fax numbers and all that sort of thing. And then you can break it out by age cohort, by race. Later on, we haven't done it yet. We have the capacity to do it. We'll go in and we'll look at health status and outcome inside the practice, and even we know what medications they're using to treat them. So with our data archive, we do a lot of publishing. We've published in JAMA, we've published in Lancet, we've published in Diabetes Care across therapeutic areas, and we do that really by partnering. We're not clinicians, but we partner with clinicians and academic centers and organized medicine across the country to publish. We do a lot of quality improvement initiative because we can see inside the practice. We work with other physicians who go in and look at guideline concordant care and making sure that patients are getting it. We use a lot of our data for advocacy. If you're not advocating in American healthcare today, you're not getting. And so we use the data to do data-driven advocacy. We also look at value assessments, and we can talk a lot about that and the negative impact that's having on minority health. Clinical research, clinical trial work. We build learning communities. So we use the data in a lot of ways. What I want to do is just walk you through quickly some case studies to give you a feel for what is it we're doing. So we all know that COVID has had a disproportionate impact on minority communities and rural communities as well, and particularly African Americans. Actually, if you go back and you look at some of the SARS data back in 2008, there were already signals that there was something disproportionate about this coronavirus in minority populations. And so, you can begin to anticipate what was going to happen with this. What we started to do is we started to use, because we're going to come up on this whole issue of vaccinating patient populations for the virus. And we thought that the predicate to that was really to understand what we were doing with the flu vaccine. So we've been doing a lot of work in flu vaccine. And actually, this is some work from Lancet, an article that we're just getting published in Lancet, looking at flu vaccines this is the Medicare population. And you can see that minority populations are disproportionately being vaccinated. And here's a sort of another look at it. So African Americans and Hispanics are about 30 and 34% less likely to get a flu vaccine in the Medicare program. And we can talk about pneumococcal is low as well. Shingles, forget about it. Nobody's actually getting it in the minority community. So a lot of data there. This is CDC data actually releasing, just looking at the hospitalizations for flu for African Americans compared to whites. And you can see, because they're not getting vaccinated, they have high levels of hospitalizations. So here we've mapped, we've gone in and we've mapped flu vaccine rates. And you can see in those yellow areas that people are not getting vaccinated. And again, this is African Americans, and you're looking at that southeastern part of the United States and up here in Detroit and Illinois. And you can see the underutilization of vaccines in that population. So what we did is we pulled together a working group of experts and tried to not only do research, but put together a whole program. And we can talk about it later on. We've developed all kinds of materials to talk about the flu vaccine, because we believe that you're not going to be able to get people to take the coronavirus vaccine if we can't even conquer getting them to take the flu vaccine. And so we have a whole website and programs and materials that we can make available to everyone to use to try to increase the flu vaccine in minority communities, but also leading us up to the COVID virus. Here, this project here, we're just getting started on. So a lot of the data that's coming out on COVID is at the national level. They're telling you by December or January, going to be 300,000 or 400,000 people who have died, and then others are collecting, like Johns Hopkins, they're collecting the data historically. But what they're not doing is predicting down at the community level, so that you have actionable data at the community level to anticipate a viral surge before it actually occurs. So we've partnered up with Quest Diagnostic. Quest produces maybe about 60% of all of the PCR tests in the country and the serology tests for antibodies. And what we're doing is we're using AI to do predictive analytics. We're looking to be able to predict viral surges 60 to 90 days out before they actually occur in population. And that way, you can go into a community, talk about the social distancing, wear the mask, and also take the vaccine in order to get those surges down. And you'll be able to go in and map by congressional district. So you can go in and tell a member of Congress, because we always think that they're important players, particularly in the Medicare and Medicaid program. So that's a project that we're working on. This is how the breakout of the death rates with the virus. This is about August data here, actually. And you can see the reason why a lot of people weren't paying attention to it is because the death rates are really clustered in certain communities, but those rates are going to turn up. And then finally, this is a prospective study that we're doing with Centene and Quest Diagnostic and others. We're trying to understand why are minority populations and rural populations disproportionately being impacted by the virus. This is a 5-year prospective study. We did a pilot started in June, which ended in August, and now we're just actually launching this study, the whole 5-year study on November 16th. We're working with federally qualified health centers in 5 states. Each center is collecting 1,000 participants, and we're running a number of clinical essays and actually doing whole genome sequencing on this population. We're partnering with the Broad up at Harvard to do the genome sequencing. And the whole idea is we want to understand: is it diabetes? Is it asthma? Is it some genetic marker? What is it that actually, at the end of the day, is creating this disproportionate outcome for minorities? We're also doing a number of ancillary studies because we're taking nothing for granted. This antibody testing study, for example, when you go in and you look at the devices that are used to measure, that is the PCR test and the serology test for the virus, none of them have been tested in minority populations. We assume that they're going to give you the same results, but we don't know that. And so we're taking nothing for granted. The very instruments that we use to measure it, we want to make sure that they're concurrent and giving us the same results. So that's a study that we're in the middle of launching. We're also going to be doing the antibody quantity test because different levels of antibodies by age and race and gender. You have potential immune senescence for senior populations. And as I said before, back in the early SARS, we saw some variations in the presence of antibodies that might explain variations in outcomes. Then we want to look at, diabetes, because people say that could have an impact, and look at cardiovascular disease. So we're starting with C-reactive proteins and other tests. And then besides, we're going to use African Americans as the reference population. In this country, we tend to use whites all the time as the reference population. But in this study, we're using African Americans as the reference population. And then we want to go take a look at other communities to see how they differ from the African American experience. And so, that's sort of a little bit of what we're doing and how we're using the data to try to understand a lot more about minority health.
Excellent. Let me ask you a question. This is almost like our own version of the NSA, that you have data that very few other people have been able to aggregate. But let me ask you a few elementary questions, because there's been so much confusion in our population. Is it, based upon what you've seen data-wise, more dangerous for people of color not to take the flu vaccine? And let's go to other vaccines, because I have a belief that people want to confuse our people to say, don't take the vaccine so we can die. But I'd like your opinion.
Well, it's always about the science, right? And so what we have to wait and see is, are the trials diverse? Did they recruit a diverse population into the trial? And then what were the results in terms of outcomes and effectiveness? Now, part of the challenge is, of course, we're doing this at warp speed. And so what we understand warp speed to mean, or at least the way it's being described, is that the federal government is paying for the drugs to be developed right now, even before they are approved. And so if they fail, the federal government eats the cost. And so the companies, if they get FDA approval, don't have to spend a year ramping up in order to get it. But to answer your question precisely, I think the jury's out. I think we have to wait and see what the data says. and make sure. Now, what we have been encouraging the companies to do, which they haven't done, is to bring us around the table, to make sure that we're at the table seeing all the numbers, because it is our docs who are going to have to administer those drugs, and they need to be confident that these medications are actually safe and efficacious, and the only way they can do that is to be part of the process.
Thank you. Michelle?
Hi, thank you, Dr. Puckering. That was amazing. So one of the questions is, how can a layman get access to the information if you're looking into the data extrapolated to a patient's zip code or doctor information, for instance? How can a layman get access to that information?
So the way we work is we set up learning communities. Often they're around therapeutic areas. And so, we have a learning community with lupus, with the Lupus Research Alliance. Us Against Alzheimer's is doing Alzheimer's. So we form, celiac has come to us, and we've formed a learning group in celiac. What we haven't done, and we'd probably be open to it, is to set up a learning community around African American health, and then provide the data that way. Because the point is, what we're trying to do when I describe a learning community is we're trying to get physicians, researchers, community, all around the table looking at the data. And I want to stop, and I want to say this because Randall hinted at it, but I want to say it more directly. The American healthcare system was built during the era of segregation, when inequalities were accepted, right? It was really late into the 1980s when physicians were still listing the idea that they needed to desegregate their practice. What has happened is we don't have the structure of segregation looking at us in the face, meaning African Americans can't go into this hospital or into this practice, but the underlying outcomes haven't really changed, right? The way in which we are reimbursing for healthcare in minority communities haven't really changed. If you look at the Medicaid program, for example, it doesn't reimburse physicians very well. It doesn't take care of patients very well. And of course, they're going to get bad outcomes. And a lot of African Americans are getting their health care through the Medicaid program. So structurally, that program is broken, and it's got to be fixed, right? In order to get a better health outcomes for African Americans. Too often, we're blaming the victim, right? We're blaming African Americans for a system that is fundamentally broken, that was built to be unequal and separate, with bad outcomes. And that's why we're using the data the way we are, because we can show that they're not getting quality care, that the system is really not really performing very well for African Americans.
Okay, thank you. Another part of that question is, how do patients have a right to opt out of this data gathering process?
Not really, because we're not collecting patient information. And when I say patient information, I don't know their names and addresses. This is all aggregated data, so it's all HIPAA compliant. So we don't know any individual. But what I would say is that they should opt out, right? Because the future is really in big data and big data analytics, right? The way in which we're coming to the place where we should be controlling health outcomes to the best of our science. We should be able to look down at the community level and control the number of people that have a cardiovascular event, that go on dialysis, even with COVID, right? We should be controlling the infection rate, and we're not. Well, we have the capacity to do it, but we're not doing it. And that's why the system is broken, because it's not doing what it can do, and certainly not doing what it can do for minority populations.
Well, let me ask you this question.
Thank you.
We met a few months ago, a group of us called the Select Roundtable. And we had people like Dr. Puckering, we had people from the CIA and other shadowy agencies and public health people. And one of the things that we talked about is this pandemic and some of the death rates purposeful? And a number of us raised those concerns. And what I hear, and I don't want to put words in your mouth, Dr. Puckrin saying that the system is not working. But I submit maybe it is working the way it was supposed to be.
Well, let me ask you this way, right? So what the healthcare system is very good at is managing financial risk, right? And not patient risk. And so it really gets to the heart of our society. Our society operates very well when it's managing financial risk, but it also is quite prepared to elevate patient risk. And it may sound extreme, but I think it's on point, which is slavery was about managing financial risk and not patient risk, right? Because you wanted to extract wealth from those communities. It's the same way, it's the same thing that's going on right now when people say, I want to open up the society, even in the face of the virus, and some people are going to die. And what they're saying is, we want to manage financial risk and we accept patient risk. And the way we think about it is the healthcare system ought to be managing patient risk, that nobody should be going into the healthcare system and getting their risk elevated. And that's what's happening to African Americans. They're going into the healthcare system and their risk is being elevated by the way in which the system is treating them. Now, is that a mass plot? I think that's the way the society has always operated. And what we're trying to do is reimagine it, create a healthcare system that fundamentally meets the needs of our community. And that's what the fight is about. That's why you got to go vote. That's why you got to get people in office, because that's where the change is going to occur, because we have to change the fundamental structure of the system in order to get the outcomes that we're looking for. And that is healthcare in the 21st century. That's the fight that we're all about.
Well, thank you. I'd like to bring Ms. Wafer into this conversation. Let's get questions from the audience and other providers that are on. She represents a major pharma company that has put out some life-saving medications recently, especially remdesivir. Ms. Wafer, how is your company looking at lowering some of the death rate, increasing the treatment rate and success? And we applaud what you've done. How do you see this being applied and being available to the general population of communities of color? How is your company looking at that? And what do you see in the future?
Well, I think Gilead is unique in that we were founded in HIV, and with HIV comes a lot of advocacy. And so consequently, we have a lot of advocates who work within the company. And, myself and several of my colleagues are involved in lots of discussions. And we are always pointing out the demographics and always asking about who are the investigators, who are the trusted investigators, and then who are the patients that are having access. Because when Corona first started, it was those institutions who had histories of doing research who got right on this. And so some of the institutions who may have not, we started doing compassionate use, and then it went to expanded access and trying to collect data all at the same time. Now there are other studies out there. So I think Gilead is doing a good job, actually. We just had, I can't think of his name. We just added an African-American businessman to our board because of some of the noise that we were making externally. But Dr. Maxey, my question is, I understand what Dr. Puckrin was saying, and I understand the need, and we know that there are social and health determinants that put African Americans at higher risk for everything. But because I've been working in HIV and I saw what the white gay community did and made people respond to them around HIV and AIDS. My question, and I typed it in the chat box, is, do you think this would be different, Dr. Puckering, if white men, the ages between 25 and 40, were dying at a higher rate than Black and brown people? Because I think it would be.
Oh, I think without a doubt, right? The country is, it was really interesting. And I won't tell the company's name. When we were getting started looking at the virus, they were pushing us very hard to include rural community because they said, and I don't think they were being dishonest about it. They just said if you said African Americans, there wouldn't be a lot of interest in doing a study that tried to understand why the virus was impacting African Americans disproportionately. America is a caste society. I mean, it fundamentally is. And so you just have to accept that reality. But the point is, what's different now is we have the capacity to vote. We have the voice that we didn't have before, and we have to form those partnerships to change the system and make it work for us. I think that's kind of where it is.
Yeah, and so I do think, being a person who works on the inside of all of this, we need more advocacy from the outside, going to these companies and saying what we need, because it's about having a trusted messenger when it comes to clinical research. And I'm sure Dr. Stevens knows what I'm talking about. I mean, I worked on those studies where we're trying to prevent transmission of the virus from mother to baby. But I thought about Tuskegee, and I sure didn't want to be Miss Evers, talking to women about these studies. And I think that a lot of women, because I was able to translate the science, they were able to opt into the studies. But I do think we need more advocacy, putting pressure on some of these companies to make sure that trusted messengers are involved in some of this research.
Dr. Neighbor Stevens?
I've been sitting here thinking and listening to all of this great information. And I think what I want to ask is, or comment on, is when the analysis is completed that Dr. Puckering has initiated around specifically COVID, it'll be helpful in planning for the next pandemic, but it's not going to, since it's a 5-year, if I understood you correctly, a 5-year project, it's not going to be particularly helpful right now. And for example, the state of Florida was particularly vigilant in preventing community doctors, health departments, anybody who had any interest in the actual infection rate in this zip code by zip code manner, because it would dispel the myth that was being propagated by the president, saying that the disease wasn't really around. And so there's a lot of information that has been hidden that would have been very helpful if it had been released. Now that we have a new approach dawning, my question is, are they going about things in the same old, or to your knowledge, are they availing themselves of not only the work that University of Washington is doing, that Hopkins is doing, which has a certain kind of static perspective in the way that they're doing it? Because what struck me about what you were describing is kind of a different way of looking at it, even though it's going to take 5 years to do it, but it is kind of a different way of looking at it. Are they tapping into your group in particular and other groups as they bring together this new task force and new approach for controlling COVID? Or are we still going down the same path that we've always gone down, going back to what we did with SARS and all the rest of the pandemics that we've had in the past.
So the reason why we are mapping and predicting COVID by zip code level and then aggregating it up to higher geography is to put the information in the hands of our community, independent of what they do, right? Now, I will say that I fully anticipate, because I know the transition team is already working on the virus, and they're certainly going to have a whole different approach to the virus. But it's been so politicized, and that they're going to have some headwinds, to be sure. But what's really important for our community is that we have our own numbers, that we understand amongst ourselves the impact, because you're absolutely right. The data was suppressed during the height of the virus. It wasn't just Florida, it was Arizona, even New York didn't release the data down at the zip code level by race and ethnicity so it could be actionable. So people were sitting on that data for sure. But that's why it's so very important that we have to have our own numbers, and we have to be confident in them. They have to be scientifically created so that they can withstand challenges. All of that work we have to do in order for our community to be confident and make appropriate decisions. If we're relying on other people to give us the numbers, then we're dependent and anything can happen. And I just think fundamentally we got to have our own numbers.
Let me ask you another question. When I was in graduate school, we were looking at the human genome and what type of toxins would affect the human genome. And even though every week we talk about you need to improve your immune system, you need to keep your hands clean, your hands out of your mouth. I know these pharmaceutical companies now are looking into the human genome at a higher level. We know that renal failure in many cases is caused by a certain set of genes that occurs in people of West African descent, the APO1 and AO2. I read an article referred to me by Dr. Gibson, who is possibly on the line, where even looking at the dangers of COVID, there are certain genetic subtypes that are showing themselves to be more susceptible. We had a talk last week from Dr. Laurel Salafu that talked about the ACE2 receptor and how when COVID gets into that receptor, it inactivates that receptor and allows the angiotensin 2 and angiotensin 1 to be unopposed, and that causes some of the endometrial, the disease of the blood vessels that causes that. What can we do? I'm speaking both and to Ms. Wafer on our side to do some of the biologic research as well as the big data research that allows us to anticipate some of these things, if for no other reason to have self-defense and not just count the numbers we're given by other people. Dr. Puckman and Ms. Wafer.
I thought you were talking to Dr. Wafer. Again, we have to do studies and run our own science. There isn't any way around it, right? We live in an environment that we have to acknowledge on its best day is ambivalent to the health of minority communities, and has not shown itself to be aggressively trying to conserve Black lives, across the board. So, I mean, that's the hard reality. And so even in the genomic data, we are underrepresented in the genomic data. We're understudied in the genomic data. But the good news is that there's a whole new generation of really bright people who are coming on stream. They have to be supported, and we have to build an intellectual community and tradition. So understand this, right? Up until 1965, we had very limited access, even to libraries, let alone colleges, right? I mean, libraries weren't even there for us. And so we have to build all that infrastructure now in order to make sure that our community is getting access to the healthcare that it needs. You can't presume that this legacy system is going to do it for them because it hasn't done it. And so that's why, again, this voting stuff is so critically important because the design of the system has to be rethought through to make sure, we all pay into NIH, but how many NIH studies are going on about minority health? I don't know, but I know it's not very many. I know that minority researchers are not getting access to it. And so it really is just a lot of work to be done. But I think it's kind of the basic stuff you have to do in order to build community and keep it healthy.
I think we need to have a meeting with Dr. Gary Gibbons and Dr. Rogers Griffin, among others, and talk about some of these basic things.
Yeah,
Okay.
Dr. Maxey, I agree with Dr. Pucker, and I think people like NIH and some of these pharmaceutical companies need to know you guys are out here too, and so some of that is some introductions. We have lots of young, bright people going into healthcare these days. There's a lot of money that all of a sudden started to flow to the historical Black universities and medical schools, and we have to get people interested in some of this research. And a lot of it is from relationships, though. These people that they call and they let them know that they're doing research all the time is because they've been working with them in the past. So I think there has to be more of a what do I want to call it? More groups coming together and having these conversations where they're important, especially with some of the top pharmaceutical companies, the Pfizers. There's a brother who runs Merck, who's got the relationship with him so that people like in this organization could be doing more research, Global Blood Therapeutics has got treatment for sickle cell now. And I know that the brother who runs that organization spoke at the NMA this year, and he's, Dr. Love has been doing some really good stuff. I think it's almost like a coalition needs to be built that can be dealt with when we need to get some of the science and some of the results of the science.
There's a certain organization that has been having summit meetings at the Ritz-Carlton in DC. I think they ought to cooperate with us and do exactly that. I think we should do that at least virtually, Gary.
I'm always up for that. I think we have to build community and take care of ourselves. I think, we just can't. The record is very, very clear, right? I mean, we don't have to go very far. I looked at 70 million people voted for nonsense, right? I mean, 70 million people, that is not a small number. I mean, that's half of the voting population raised their hands and said, I want some more of that. I want some more of that stuff. And I think a lot of it had to do with race, just fundamentally. Otherwise, it doesn't make any sense.
You think? Yeah.
Well, but they want to say it's socialism, progressive agenda. It's not that. It's race.
It's race.
It's just
all
race. Right? And so when you're staring that in the face, you have to say, okay, so that's the hard reality. Now, how do we go build a system that takes care of our family and our children and protect us and let them go do what they do? But we have to use the powers that we have in order to create a healthcare system to take care of.
I think the other thing too is that I'm old enough to have participated in a lot of revolutionary acts, and I know that those of us who had the opportunity to go to college, that's our job, is to help the folks who didn't get the break that we got. And there are folks who are, waiting for us to do that. And I think that's something that right now is if we can build the types of coalitions that if something goes down and we raise our voice, it's like E.F. Hutton spoke, you know? I think that's where we could get to.
Okay. Yeah, we're coming close to the time where we close the meeting, but on this phone, there are a number of people that need to come together. One is Mr. Carl Brooks, who has a connection with a good 90% of the top Black Fortune 500 executives in the country. Dr. Puckrin, who has a meeting of healthcare professionals every year. A number of others, including Ms. Wafer, and a number of our healthcare professionals that are on this call. And I think that we need to, within the next 2 weeks, have a phone call about, there's also a group called the Blacks on Wall Street, a group called Wade in the Water. It's time that we coalesce these forces for our betterment and not always just go off into different directions. Before we close up, Michelle, are there a couple of good questions in the chat box?
Well, there's a couple of good questions, and also Dr. Clark would like to jump on and insert something if there's time. But before we do that, I just want to clarify real quick. Did you say that shingles was not an issue for the African-American community?
No, I was saying access to the shingles vaccine is a problem.
Access to the shingles. Okay, I just wanted to clear that up for anyone who's
That
waiting for that answer.
thinking that they should be taking it.
Oh, absolutely.
Okay. How do you become part of the process for the database? Are you invited or do you apply for admission?
I sent my email is on my slide, so they could just send me an email and we'll get them connected to a community.
Okay. And let's see, hold on. So we do have, well, I'm not gonna go with that. Okay, well, Dr. Clark, do you want to jump on for a sec?
Okay, thank you. As regards the mentorship, I think one of the most important things we need to do is make sure that our young people know who they are. As evidenced by what we see with the young, relatively bright, but uninformed young rappers, other individuals that were supporting somebody who was clearly racist. They didn't understand who they were. They didn't know their history. It's not being taught. It's not something that they were taught to seek. And so we need to support them in that because, you know, from the unrecognized primary care specialty of psychiatry, this is our challenge and this is our charge to help them with the suffering, to help them understand how to cope with the reality of being Black in these Americas. That's all I had to say. Thank you.
That's important, what you said, Dr. Clark. We appreciate that.
Howard, looks like, Howard, you have something you want to close out with?
Basically, can you hear me?
I can.
Basically, you know, what Ms. Clark just said, and because when you talk about the rappers and stuff, a lot of misinformation goes around, and it's so important for us to strengthen that communication between each other. A lot of rappers, you know, they heard, you know, that Joe Biden will raise taxes when he gets into office. What they don't understand is that they're going to raise taxes on 400,000 plus if you make 400,000 a year plus. And, you know, but they see 50 Cent or whoever it was. And I used to say Lil Wayne, but I don't even include, I don't know what's happening with Lil Wayne, but like, as far as the information, you know, I'm sure that a big majority of, I'll just say 50, I don't know if he was serious about it, but of his followers don't make $400,000 a year, you know, but they don't understand that because of the misinformation that's out there, the misinformation as far as even the rappers that went and they attached themselves to the Trump organization. I mean, the main goal for the Trump organization was to secure 20% of the male Black votes. You know what I'm saying? So that was his main thing. He wasn't about, you know, and if they don't take the time to really research things, which we're famous for not researching things, and you can't let the internet and especially social media shape your opinion about something, because what they're trying to shape your opinion to what they want your opinion to be. So it's about research, and it's about really taking the time. I think, you know, because like I had said, once the elections were done, even before they were done, was that, you know, we'll be successful in the vote, but that's just the beginning of what we need to take care of, and the beginning of the work that needs to be done. You know, information, making sure that we communicate with each other, making sure that, you know, stuff like this, you get informed about, and you understand why, you know, like I said earlier, some people were wondering, okay, why is COVID-19 disproportionately more, you know, we're more susceptible to COVID-19 and to HIV, whatever, and all that kind of stuff. You got to understand why. And you know, communication is the key as far as that's concerned. And, you know, it has to be like you know, Mr. Pucherin and Dr. Maxey, Ms. Wafer is, you know, and we have to develop ways of communicating, especially with young people coming up, you know, about what's going on. Because like I tell them all the time, I say, hey, this is your world that we're up here, you know, fighting for. You know, this is your world. If the Lord blesses me with another 20, 25 years, I'm good. You know, I'm cool. But, you know, it's like, but it's, you know, like my daughter's, you know, my youngest daughter's 24. I said, you know, this is her world. I'm so happy and proud that I see her researching everything that goes on. But everybody has to do that. We have to, as a people, it's up to, they're not going to tell us what we need to know. You know, they're not going to tell us what the deal is. We have to go out there and not have that, you know, crab in the barrel type of mentality, not have that, you know, type of situation where, you know, we see somebody else getting ahead. We be so divided and so splintered as a people. And I think that that's the most important thing. I mean, just sitting here, you know, listening to you guys has like, you know, enlightened me about a lot of stuff, you know, and I know that if we could get some type of format, you know, to, as far as our young people are concerned, you know, to try and get them involved, get them, you know, understanding that this is what's happening, that's what's happening, you know, and you know, it's very important. Nothing, and that's that foundation. We're the foundation. You guys are the foundation. We're the foundation right here. And as sturdy and as strong as that house is, it's going to depend on how sturdy and how strong that foundation is. And us being a foundation, I'm a foundation guy. I mean, I don't believe anything can stand without a strong foundation, you know. So, you know, we're the foundation. You know, you guys with your information is amazing, is helpful, is you know, is amazing, but it's only good if we spread it. It's not cool when it's not any good when we just sit on these Zoom calls and talk about things within each other. talk about things within each other so to strengthen each other up so that you can spread that that foundation and that security and that strength, to where we need to spread it to strengthen our foundation as a people, because, and I like to say too, real quick, just on the political side, like I said, we sat Donald Trump down yesterday. Thank God we sat Donald Trump down yesterday, but Kentucky was not able to get Mitch McConnell out of there. But we have an opportunity to shut Mitch McConnell down also with those runoffs that are happening in Georgia with the two seats that are empty. I mean, not that are empty, but that are going into the runoff. So we need to really pour some information and all that kind of stuff into that whole process also. With the little platform I have, I'm going to be, putting as much information out there as I can as far as the importance, because some people think we did the presidential election, our job is done. No, the job's not done. That's just the beginning. All these other elections are very, very just as important as the presidential elections. That's all I have.
Thank you, Howard. Outstanding. Dr. Maxey, I'm going to unmute you now. Dr. Maxey, you're muted. There you go.
Good. I want to tell Mr. Hewitt, you're going to give me an even bigger platform with that God-given voice you have, but I'm going to call and talk to Dr. Puckrin, Dr. Brooks, doctors who lead the National Medical Association, ABC. We know that being convened tomorrow is going to be a special task force on COVID. And we know that some of our members are involved in that. And we're going to put together this summit or semi-summit to do some of these things very practically. We would like to grow our database. I know we've had a lot of technical errors of people who want to be included in some of our calls and mail outs. Please put your emails. We have a website at blackhealthtrust.org. And I think there's a communication mechanism on there that we can get your email, or you can send them to our email at blackhealthtrust.org. And we'd like to do that. I'd like for our hostess, Michelle, to invite people to put information into the chat box. We can store it, and then we can get back to them. Our program next week, we've got a world-class cardiologist, Dr. Mason Weiss, who's going to present on the cardiac disease associated with COVID. We've got pulmonologist, Dr. Paresh Patel, speaking on the lung aspects, and a number of others. We have a strong program. We're going to be doing this every week. We're trying to cut down our time so we don't interfere with too much football. I understand that that's an issue. Dr. Nabert Stevens, thank you so much. Have you got a final word before we close?
And Dr. Maxey, I've just got to put this out there. I get this question all the time. What prenatal vitamins are you taking? People need to know.
Well, I'm not.
You're not promoting it with what?
I do take prenatal vitamins, but I don't honestly know the brand. The drugstore just sends them to me, but they've got all the micronutrients because I probably don't eat as well as I should, as many salads as I should. But I'm going to ask Mr. Admiral Brewer to come back in the near future and give us his elderberry syrup and recipes. Dr. Tyler also gave an excellent talk on nutrition, as did Dr. Lisa Kirban-Dawes. We'd like to keep doing this and expand it. And Dr. Puckrin, I'm going to give you a special invitation to our medical advisory. I think your big data needs to be presented to the doctors of Black Health Trust again in expanded fashion. Dr. Neighbor-Stevens, you have a final word, and we're going to get off of this call.
Well, my final word today is I think we all see that we have our work cut out for us. We need to take heart in the fact that we have the soldiers needed to get the work done. It's just a matter at this point of getting ourselves organized into an effective group to push the buttons that need to be pushed and to get the things done that need to get done. The other final word I want to leave you with is we've got soldiers now, but our pipeline is anemic. And so we need to do everything that we can to support our children, encourage them in their interest in science and technology, support them in their academics so that they make the grades that are needed to get to college, and then from college to medical school, or if they want to follow a science path, get into the science curriculums. We are the ones who are the only ones really who can support our young people and, if necessary, push our young people in the direction that they need to go. If we don't start doing that, you think you can't find a Black doctor now. In another 10 years, we will be extinct. So please work with our young people and encourage them to follow the health career pathway.
And I, as my final word, want to say a special thank you to my friend since 1961, who's the founder of the Cool Jazz Festival, the Newport Jazz Festival, Mr. John Sudokas, who's responsible for bringing our Grammy-winning entertainers to the table to share their wisdom with us, such as Mr. Hewitt, Mr. John Sudokas. Thanks, everybody. See you next week.